Yeah, put him on the side.
I feel like mine is big. It's like I usually have 0 coverage. And there's something, and I'm like, I'm say whatever, show whatever. You know, that's why I like in a practical class.
Do you hear them?
But I think people think that it's like, oh my God, it's a whole thing.
Still good?
Wow.
Don't mess this up. You ready, Dr. Lee?
I'm ready. I was just waiting for it to click for 7 minutes. Want me to shut it? Who's supposed to be?
You are you.
Will? Is it Will? Was.
I think Beth takes over. She's like recording. Yes. Dr. Lee,
Yeah,
do you know who else is supposed to be?
I don't.
You want me to just?
It's time.
Alright. Well, welcome everybody. Does this sound okay for like the millionth time?
It's a little fuzzy.
Better?
Yeah.
Better now? Okay. Welcome. We're going to talk about a patient who had a complex CVA with some symptoms of Usher syndrome. So the purpose of my presentation is to provide some insight into the clinical decision-making I use to treat this patient, as well as to discuss the importance of referrals throughout the treatment and the importance of patient and family education. So the general plan for tonight, I'll give you guys a brief history of the patient I saw. We'll discuss the initial evaluation, and then the way I set it up is a timeline of the treatments and the additional services I provided, so it's going to be in sequence. I'll kind of sum up a couple of weeks and then dive into the interventions to give some more explanation as to why we did them. So, meeting the patient. So, this is my patient. She's a 7-year-old female. Her CVA occurred on September 4th, 2016. She was admitted to VCU Hospital, where they did imaging, and she was found to have a hyperdense right MCA, occlusion of the right M2 artery, and embolic basal artery. So basically what I was thinking, hearing that, is involvement of the more motor and sensory cortex and possibly some of the communication. That basal artery also goes to that cerebellum, so possibly some coordination as well. So after she was discharged from the hospital, she was admitted to the acute inpatient at Virginia Baptist Hospital, where she received PT, OT, and speech for two whole months. Where then she was discharged to home health, where she received 2 months of home health of the same services. So before she came to see us in outpatient, she's already received 4 months of therapy. And luckily I had some access to some of their treatment notes, so I could kind of get an idea of what they were working on as far as PT went. They were really at home working on that mobility transfers and trying to do a little walking with her platform walker that she had. So she came in, and the way I like to start my evaluation is kind of build a rapport and just confirm the history with the patient and her caregivers, which were her husband and daughter who came with her. So confirmed everything that I had already read, see how everything was going since the home health discharge, and then find out a little more about her. Before she had the CVA, she was independent with everything. Cooking meals, she was driving, her exercise was 30 minutes of walking daily, and all that changed drastically. At this point, they are still reporting difficulty with walking, getting out of bed, standing, and transfers. Everything needed some form of assistance. And so that was kind of, to me, an important thing, is trying to reduce the amount of assistance that they were needed. Another thing I thought was important, she hasn't had any falls since the CVA. I thought that was important because at home they're taking safe precautions to make sure she's not losing her balance and falling and possibly creating further injury. So moving on to my examination, starting with the observation of her posture and sitting and standing, noted left upper extremity and left lower extremity synergies. Now, going forward, since she was receiving an OT, I didn't do any testing on the upper extremity. We left that for the occupational therapist to do. So we focused on the left lower extremity. She also had a posterior lateral lean towards the affected side. So she was sitting in her wheelchair at this time, which wasn't fitted properly for her, which we'll get into a little later. Leaning towards that affected side. Did not look comfortable, constantly moving around, trying to get in a comfortable position. Did modified AFERS testing. She was 2 out of 4 in her left lower extremity, which is marked increase in muscle tone through most of range of motion, but can still be easily moved. And then we did some coordination testing with rapid ankle movements and heel to shin. She was not able to keep the rapid ankle movements and speed it up, and then heel to shin, she was all over the place, letting the heel slide past, so it was more like her calf was on her shin. And then the next thing I wanted to do was get her up and see what she could do walking, since I saw she was doing some walking at home health. We used the left platform walker, so her involved upper extremity was on the platform, right arm on the walker. It required max assist times 2. We had one person helping with stability of her trunk, keeping her balance, and then the second person was helping advance that left lower extremity and get the walker moving forward. She had deviated gait pattern, she had scissoring of gait, inconsistent foot placement, heel strike and toe off. And during the swing phase, it went right into a flexor synergy, so that was difficult for her to come out of that and place the foot. And then during stance, her ankle stability was really poor, and she severely supinated, so she was basically walking on the lateral aspect of her ankle. And then the other thing we noted was with the walker, she would use that right arm and kind of push away, and that's where that kind of symptoms of the pusher syndrome came into play, we thought about. But with some verbal cueing, she was able to reduce it, so we didn't go and do any further pusher syndrome testing. And then we went on to do a burr. She was only 3 out of 56, high fall risk. She was only able to do sitting posture, and with the sit to stand transfer, she got points. She wasn't able to stand independently, so she did not score any points on any of the standing activities. The other observation we made during the examination was her wheelchair. It was not fitted properly for her, and I have some pictures later on, but we were thinking about that long term, possibly getting a new wheelchair that would be better for her. So this was our assessment, our PT diagnosis. The main one is the unsteadiness on feet, to me, because that limited how much she could do independently in the house. Difficulty walking kind of comes with that as well. Prognosis, we said was limited due to the severity of the stroke and the results of the previous PT and OT. So we're seeing her 4 months out from the stroke, and the primary part where you want to make the progress is within the first 3 months. Since she still had a lot of severe limitations, we weren't sure how much more we were going to do. So that's where our PD goals, we didn't set any to necessarily get her independent to walking. We weren't sure if we were going to be able to get to that point. So our main thing was trying to decrease that flexor synergy, improve ease of transfers, and improve balance in general, sitting, standing, and when she was walking. So our plan of care, we'll see her 3 times a week for 12 weeks initially. Again, these are our goals that we wanted to achieve. They lined up with her goals. Her main thing was just trying to get back to her life, being a little more independent. And as far as her husband and daughter, they wanted to kind of ease the burden of care on them. So their life would be a little easier. The evaluation for the power chair, we wanted to do that. Again, taking in consideration the progress she has already made and where she's at, we felt that would be better long-term use for her. And then she was also receiving OT at our facility. Speech was completely discharged at the end of home health. So going into our first week, we did block treatment sessions, really getting that repetition from session to session, see if we can get that carryover, get that neuroplasticity change that is required. We started with the peanut patterns to reduce that flexor synergy. And we provided that as a home exercise program. So we spent a lot of time teaching the daughter and the husband how to perform, making sure they were doing it correctly, hand placements. We thought it was really important to be doing that daily to help reduce that flexor synergy. We also reviewed some prolonged stretching positions to be performed afterwards to prevent any contractures since she was primarily in her wheelchair. And then we also started trying to do some standing balance exercises to try to get some weight bearing through that left lower extremity to work on the balance and also help reduce that flexor synergy as well. So we continued that for the second and third week. We introduced some resisted peanut patterns as the flexor synergy started to decrease and try to build some more strength in that coordinated pattern. We started like a treadmill training. And I use a makeshift AFO, which I'll explain in a little bit. We work on stand transfers, doing some NDT transfers to help the coordination with those, and then also teaching the daughter and husband better body mechanics as well to make sure they're not going to injure themselves at some point at home. And then this is where the wheelchair evaluation occurred during this time. I'll go into a little more detail in just a minute. So the light gait treadmill training. So this is a picture of her in the light gate. So research shows that using the light gate helps with coordination, confidence, takes the chance of falling away from the patient so they can really focus on what our task was. So on the treadmill, it was a constant pace so we could get some good sequencing of steps, and I could help with the positioning of that left leg during. So the makeshift AFO we did to help with that ankle stability, it was just a posterior leaf spring and then an ace wrap to wrap into a pronation position to just stabilize that ankle. And once we did that, we did notice a little better, more stability, and she had a little better proprioception, so her foot placement was a little better as well. So once we kind of saw that from treatment to treatment that was getting better with that, we wanted to possibly look into getting her a customized AFO in the future. And then talking about the wheelchair evaluation we did during this time. So these are pictures of the wheelchair she came in with. Even though she's smiling, she was generally a happy lady, but she said it wasn't very comfortable and she was constantly changing positions. So our main reason behind doing that was she couldn't independently propel that wheelchair, and it limited her independence. So we thought a power chair with a joystick control and some other unique features would be able to have that independence so she wasn't always relying on someone at home to help her with every activity. And again, just decreasing that burden on caregivers. In this thinking though, we weren't giving up on working on walking by any means, and we didn't want them to feel that way. We just wanted this to be an option long-term for them at home. So we came up to the first progress of it. First, the patient family stated they noticed an increased ease with the transfers and bed mobility. When we assessed that, they were getting better. Still requiring assistance, primarily upon standing, she would lose her balance. So that's where she required most assistance. Since I was doing PNF patterns every session, I noticed a decrease in that flexor synergy. So that was, the peanut patterning was working. I felt comfortable with them doing it at home, thought they were doing a good job of it. And then we were able to perform the tug for the first time. She completed it 4 minutes, 14 seconds. The main thing I want to point out is she was max assist ×1 instead of 2. And then the other thing I didn't mention, when we walked in the clinic, she could only walk 10 feet before she needed a break and she couldn't walk anymore. She was tired and just needed to sit. She wouldn't walk anymore. She still had posterior lateral lean in sitting and standing, but it was getting slightly better, and that comes with the light gait training. But we hadn't done any specific balance activities yet. So going forward, we did start to initiate that. We continued BNF in the gait training. We did some wedge training, and then about that AFO, we contacted a CPO to come in and help do an evaluation to see if she would benefit from it. So the wedge training we did to reduce that posterior trunk lean. We placed the wedge under her legs to encourage an anterior weight shift. We held the position for 3 to 5 minutes at a time. That's what she could tolerate. A couple of times, and then what we would do is we would step off and do some ambulation in the clinic with the rolling walker. And there was noted carryover each session that we did it. She still required assistance to stand and ambulate, but it was getting better. And getting her on this was the challenge. She was kind of scared to do it. She hadn't been standing by herself, and her not holding on to anything was a big accomplishment at the moment. She always needed to hold on to something. So going into the AFO that we got, the CPO came and he agreed that she would benefit from a custom AFO to help that stability and possibly also reduce some of that flexor synergy. So these are just pictures of him casting it. Unfortunately, I didn't think about taking a picture of the final custom AFO, but 2 weeks later, she received it. That day, we ambulated with it, and it was a drastic change. She felt so much more confident and comfortable walking. Noted improvement in foot placement and just stability throughout that left leg. And she walked, I think we walked that day almost 200 feet. So she was getting a move on. So we came up to our second progress note, so 20 visits. Again, family reported continued improvement with transfers, and as we did testing in the clinic, it was getting better. Primarily, the main thing was, again, upon standing, she didn't have that balance control, so she needed assistance, but she was doing better as far as initiating the sit to stand. She cut her tug time in half, and the assistance level went down. I really think that was a lot with the AFO, because it just provided her with that confidence and stability that when she placed that left leg down, she wasn't going to go anywhere. Her grip score improved. That was more with the sit to stand transfers. She wasn't as dependent on her upper extremity or any type of assistance. So going forward, we continue balance activities in light gait and gait training. I think it was in the 8th or 9th week, our treadmill broke. So we kind of had to end the treadmill training, but we did still do some overground. The research shows treadmill does have a benefit, but overground is equally as good. So we still did some gait training. We started using some mirror feedback to help with that postural alignment, because she was still having that posterior lateral lean. And then we updated her exercise program, providing some Frankel coordination exercises. And then on the 27th, they expressed to me incontinence issues at night. So we talked about referring to a pelvic health PT to see if there was anything they could do to help address that. Which when they went to that appointment a couple weeks later, they said some of the advice they had given her has already started to help, and they were possibly going to go back a couple more sessions to help. So I thought that was a really good referral, and I wouldn't have thought to ask, but I'm glad they brought it up because I think it's going to benefit them long term. So these are the Frankel coordination exercises, a couple of them. They're movements to improve lower extremity coordination. We gave them as a home exercise program. We did them a couple of times in session to ensure they could do them correctly. And again, education to the husband and daughter on what correct performance is, so they could watch at home. our hope was just to regain some coordination control of that lower extremity and hopefully improve gait mechanics and general standing balance. So postural re-education. We used the mirror. We had a full-length mirror in our gym. Threw a piece of tape up vertical so she could use it to find her true vertical. We did sitting and standing activities in front of the mirror. And I noted that she was able to self-correct so much better by seeing herself instead of me telling her, you're still crooked, you're leaning towards your left, go to your right. She was able to self-correct. So I think the carryover from that, from session to session, was a lot better. We would start sitting on a mat and she would be a little more true vertical. So that was working. So we continued with that and utilized that a lot going forward. So we came up on progress note number 3. So she continued improvement with transfers and walking. They were saying they were walking with her at home, handheld assess, and not using the walker, which we encouraged them not to do. Even though they said it was fine, she was doing well with it. It wasn't really promoting that potential independence with rolling walker, handheld assist. She would always need someone with her. But that being said, she was still walking, which we liked. Her tug time continued to improve, and transfers still required that mod the max assist primarily for balance. But upon standing, she wasn't leaning and swaying as much. So it was getting better, but she still couldn't maintain that upon standing independently. Bed mobility at this point, mostly independent. The only thing she had a problem with coming from her effective side up, and that's just due to that inability to really straighten that left arm to push. And at this point, me and my CI had a conversation about possibly changing focus. Even though she is making improvements with the tug and her gait, we're still realizing that she may not be independent long term. And since she is getting the power chair, we thought it would be appropriate to change focus on the sitting and standing balance, so she could possibly be independent at home, cooking a meal or preparing coffee, something like that. So we had that discussion with them. They agreed. We still encourage them to do walking at home, that it wasn't a stop to that, and we would still do some walking in the clinic, but our primary focus would be sitting and standing balance. So again, we continue postural re-education. I looked up some butcher syndrome treatments to really specify on that, or focus in on that lateral lean and try to reduce that. And then thinking about discharge coming up, we started redoing transfers just to make sure they were going well. So this is one of the butcher syndrome treatments we did, standing with support under the involved side. So by doing that, we encouraged the weight shift opposite of the way she was pushing, and almost overcorrecting to where when we removed everything, she'd be hopefully in the middle. I saw a lot of improvement with this. We did other ones where she would be leaning against the physio ball, standing, and doing reaching activities with her hand or sitting. We got to a point where we sat on a Arex and she was rolling a ball out to the side and also doing other reaching activities. Initially, when she came back, she really went back to that left side. So she improved her control to where she could come back to a neutral position and not lose her balance. So the last session I had with her, we had a discussion about discharge. She was beginning to plateau. We were working on a lot, but it was small improvements. And then we talked about therapy burnout with them. They've been receiving therapy, going to doctors for 7 months at this time, straight. So they haven't had a break. And we talked about they may benefit from some time away, get back to their lives, see where they're at as far as being on their own and see what she can do. We heard they were getting their power chair in the next couple of weeks. So we thought that would be almost perfect timing. And then at the time, OT was put on hold because that left wrist had such a flexor synergy and spasticity. They wanted Botox to help reduce it. So they were planning a trip to the beach in a couple of weeks, so we your thought, perfect time in discharge, go have fun, see what life is like. You can always come back, and we can pick up wherever you need help. So my limitations and learning points from this experience, the evaluation was early in my rotation, and it was a complex patient. My CI even said it was one of the more complex she's seen. So I think my outcome measure testing was limited. You can see I really only did Bergen and the tug. I think there were probably some more stroke-specific outcome measures I could have performed. But again, just kind of what the clinic was using at the time and then my experience, it definitely limited me. And then my interventions, I would say I was really basic with what I knew. And so researching, talking to my CI, expanded that greatly. And I think that was a great benefit. And then education is very important for patient and family. A lot of times they may not understand fully what's going on or what you're doing. So being able to explain what you're doing, why you're doing it, I think it just got everyone on board with everything, every treatment session, and it developed a good relationship with me and them. They trusted me with everything I was doing because I was able to explain it to them. So I think that was a really important point. Yeah. That's it. So any comments, questions, suggestions from anyone but Dr. Lee to start? All right, Dr. Lee.
He sat in on a couple, so he knows what's coming.
Yes. Maybe.
Yeah, just going back, this is a really broad one, so just kind of talk us through your thought process in your initial evaluation. How did you prioritize the impairments and the interventions that you did?
So in reading the other PT notes of what they had been doing, there were certain things that I knew I didn't think I really had to retest, such as like sensation. And one thing I did want to test, looking back, is proprioception. I don't remember reading anything in those. I think that would have been important to test. But from the couple weeks I had been there, it was a lot about function and mobility. So the main things we wanted to look at were how is she getting in and out of bed, hormone transfers, can she stand and can she walk? And the main thing we saw is that flexor synergy in her left leg prevented a lot of those movements and mobility in general. So that's where we prioritized reducing the flexor synergy first to see if that made any improvements, which it did. And then once we felt like it was decreased to a good point, we could do other interventions. That's when we began the treadmill training and the balance exercises. So I don't know if that answered that.
Yes,
A little good.
that is starting to. No, Emily can answer. It answered some.
Yeah.
But then, like, because you didn't really get into the balance and the postural stuff until like we wrote it down.
I think it was
way into it.
way into it.
And like, and you're seeing right from the beginning that she couldn't even hold sitting balance because she's all over there. I'm just wondering why.
Well, I think, again, part of that, I think that was my inexperience, like clinical inexperience, and really maximizing our sessions initially, because I think I did spend a lot of time on the education for everything and really building a rapport with them. But we did, again, really working, we did sitting and standing balance without walker initially and just trying to sit on the edge of the mat. It wasn't, I guess, as big of a focus in the beginning weeks, but we did do some, not as much as I think it was in the 5th week, we really started to ramp up some of the balance exercises. But again, part of that was that flexor synergy. It did take a couple weeks to reduce it to a point where we felt she could actively like come out of the synergy to put support and weight bearing through that left leg. So, I mean, I do think we could have started earlier looking back on it now. So learning from the experience, definitely would try to initiate that earlier.
I guess you sort of already addressed this one too. For please y'all, don't, I said the facilities outcome. The board was not created to assess a facility.
No.
So pick ones that work for the patient. So reflecting back now, there was an obvious floor effect of the board.
Mhm. Yeah.
Can you think of another outcome measure that would have been more appropriate for her level?
I think the stroke rehab assessment movement would have been good. String, yeah. Is or the FEM or Fugelmeyer for lower extremity. Those could have been done, but again,
So
I
the
think at the
Fugelmeyer's
time,
at an impairment level.
Yeah.
So like if you wanted one that hit functions, that's what you were
Right.
thinking.
yeah, and again, I think at the time it was just I hadn't seen those used in the clinics, and this was my first neuro experience. So, and again, I hate to use that as an excuse, and it's not on the clinic. As a new student learning these, I should know better. But I do think some of it was just me being nervous as my first like complex neuro eval, just doing what I had seen and not doing what I know. So again, looking back on it, learning from it, there's other outcomes I would have done that would have definitely have been more appropriate than doing the burger.
Yeah. And you had said you would have done others. I just wanted to see like what others might
Yeah.
have thought of.
And doing the presentation, that's one of the things I realized reviewing the notes. I was like, man, this curve is not appropriate at all. There's so many other ones I could have chosen to be more appropriate. But
Now, and you said like she was stuck in this flexor synergy like really strong, and yet there was a strength grade of 2 out of 5. Did you think about Brunstrom levels instead? Or kind of
we didn't
describe it
formally
more?
test strength.
Okay, because I saw 2 out of 5.
2 out of 4. That was the modified Ashford
Oh,
scale.
sorry.
So it was 2 out of 4 for that, for the modified
Yeah,
Ashford scale.
don't put out of 4. Just say modified Ashford was 2 plus. Okay. What Brunstrom stages to describe function
Again,
of the limb, not.
didn't think about it at the moment, but
So you had the opportunity as a student to bring new knowledge to
Yeah.
the clinic. So,
yes, again, I agree with that. I think,
it's okay, I'm really not trying to put you on the spot.
no, you're fine, trust me.
What about in your examination? I didn't see anything on cognitive or perceptual testing. Did you do any kind of screening?
So we didn't do a screen, but as far as that goes, she was able to communicate. She had good recall of everything that was going on. And I think from the notes we were reading, there was nothing abnormal that they had been treating as far as cognition or communication. So we didn't do any screening for that.
What about the perception?
We did not do any screening for that. Did not think about it.
So usually with a power
Yeah,
chair.
I just wanted to let you know that we have to make sure we have time set up for the last one, so.
So shut up, lady.
Um,
Okay.
But
You're off the hook.
there was nothing obvious as far as perception that we noticed throughout the treatment, so we thought the power chair would still be appropriate. So. And she was gonna get training with it once she could get it, so.
Sorry.
Thanks, everyone.